I'm Dr. Chandramukhi Mathur, and today's topic will be superior and middle cluneal nerve entrapment, a cause of low back and radicular pain.
Dr. Chandramukhi, you can bring it to the slideshow. Like you can press F5 or, there is a icon below in the slides where you can increase and decrease the volume, just left side to that.
So today's topic is superior and middle cluneal nerve entrapment, a cause of low radicular back and radicular pain. Authors are Helen Karl, Sandiford Helm, and Andrea M. Pressott from Pain Physician 2022, volume 25. Just a second. So a bit about the background. It is that superior and the middle cluneal nerves are sources of low back, buttock, and leg pain. They are the cutaneous branches of the lateral branches of the dorsal rami of T11 to S4. And they cause pain because of entrapment or dysfunction of one or more of these nerves. And this leads to cluneal nerve syndrome. A clear understanding of anatomy and treatment has been hampered by the very small size of the cluneal nerves and their complex varying anatomy, as well as a confusing and contradictory literature. So the objective of this study was to provide a thorough critical literature review of cluneal nerve anatomy and implications of the therapy. The study design used was a modifying scoping review, and the methodology was the bibliographic trail of English language papers on the anatomy and treatment of cluneal nerve syndrome were used. For low back or leg pain, the greatest focus has been on the intervertebral disc, the lumbar facet joints, and the sacroiliac joint. The role of peripheral nerve entrapment has been overshadowed by the spinal causes of pain. Cluneal nerve disorders specifically were first described in 1957 by Strong and Gloll, and the word cluneal derives from the Latin clunes, and the English meaning is buttocks. Only the superior cluneal nerve and the middle cluneal nerves are significant, and thus being sources of low back, groin, leg, or foot pain. This review will therefore focus on the superior and the middle cluneal nerves only. So basically the study questions are, what is the known about the anatomy of these cluneal nerves, and how does that knowledge assist with the diagnosis and treatment of low back and buttock pains? The methodology was a scoping study. The scoping study addresses a broader topic where many different study designs might be applicable, and a scoping study requires far more analytical interpretation of the literature as compared to other studies that are generally done. And the results of literature search were out of 12 recent surgical reports, 9 anatomical studies, and the majority of this work was conducted by the researchers in Japan. That I'll skip. So coming to the anatomy, we say that each spinal cord segment, it has a dorsal segment, dorsal sensory root, and a ventral motor root. And these combine in the intervertebral foramina to form the spinal nerve. And this has both motor and sensory fibers, and this divides into a dorsal ramus and a ventral ramus. The dorsal ramus branches the medial branch, the intermediate branch, and the lateral branches. The medial branch is generally seen to innervate the facet joints, the multifidus, and a smaller area medial to the facet joint around the skin. As far as the intermediate and the lateral branches go, in this diagram, we see the labeled branches. The ones in green are intermediate branches, and the ones in yellow are the lateral branches. So Johnston, he emphasized that these branches, they have a long, somewhat curved course, as you can see. So as they reach their termination to the skin, they have a long and curved course. This is necessitated because of the extensive movement of the spine and the hips. So frequent communication of these nerves, with one another has been seen. And also there is a variation that exists between individuals and also within individuals. As far as it's been seen that the right varying even from that on the left in the same cadaver. So this has actually been seen. So therefore, there is a need for a careful physical examination and also a low volume of the local anesthetic diagnostic injections that would be required. So a bit more about this anatomy. As you can see in this diagram, this is the transverse section in the lower lumbar region. So here we have the multifidus. MF is the multifidus, LT is the longissimus thoracis muscle, and IL is the iliocostalis lumborum muscle. So these are covered by a fascia that is called the thoracolumbar fascia or the erector spinae fascia, ESA, that's been labeled. A facial plate, that is this one, the lumbar intermuscular aponeurosis, the LIA. This extends from the thoracolumbar fascia to the transverse process, separating the longissimus thoracis from the more lateral iliocostalis lumborum. And in between these, there is a small FS space that is called the fat-filled space. And through this, the lateral and the intermediate branches travel. I hope these are all clear.
Yes, yes, yes.
So between T11 and L4, there is usually, this is again the same diagram. Between T11 and L4, there is usually an intermediate branch, and in addition, the lateral branches. The intermediate branches, they communicate with the branches of the nearby levels, and also they terminate in the longissimus thoracis, like here. And these branches from the L2, 3, and 4, they continue as the superior cluneal nerves. And these may extend up to the skin. Whereas the lateral branches, these yellow ones, they cross posterior to the transverse process here, and they travel caudally, laterally, dorsally, and through the iliocostalis lumborum, this one, and they innervate it. So the superior cluneal nerves, these are the cutaneous branches of the dorsal rami of the T11 to L5. So they either pierce the thoracolumbar fascia, which is here, superior to the iliac crest. This is like the iliac crest, and they pierce either superior to the iliac crest through the thoracolumbar fascia or inferiorly through the gluteal fascia, inferior to the crest. And then they become superficial and innervate the skin over the upper two-thirds of the gluteal muscles as far as the greater trochanter. It's been seen that the most medial orifice is located generally at 7 to 8 centimeters from the midline. And the nerves, they pierce the fascia caudal to the iliac crest, and they pass through a fibro-osseous tunnel that I'll show in the next diagram as well. So this is the fibro-osseous tunnel. So generally, whenever they're passing, they pass through a fibro-osseous tunnel. The superior cluneal nerves, these are grouped according to the distance from the midline. So this is the most medial, the intermediate, and the lateral superior cluneal nerves. And injury has been seen mostly involving the most medial branch of the superior cluneal nerve. The branches, they can arise from any of the nerve roots from T12 to L4 or from multiple nerve roots. The nerve roots supplying any one branch of the superior cluneal nerves, they do not need to be adjacent to that. T12 and L2 can also give rise to one branch. As we see in this diagram, so L2, L3, they form the superior cluneal nerve. Similarly, from here, on left hand side, we are seeing that the T12 and L2, they are joining to form this nerve. L1 is going on its own way. So similarly, there can be any sort of permutation combination right from T12 to L4. And this calls for the variation that has been seen in the superior cluneal nerves. So different authors have presented different findings as to the nerve root of origin of most medial branch of the superior cluneal nerve as they traverse the iliac crest. Main found that L1 was the most common nerve root, but recently Kono found that L4 and L5 also contribute more. So the clinical relevance of this is because most medial branch of the superior cluneal nerve is most likely to be entrapped by the fascia as the nerve crosses the iliac crest, because the fascia is thickest towards the midline. So given the role of superior cluneal nerves in causing buttock and leg pain, Kono's findings appear to support what is seen clinically, which is back pain as well as pain radiating down to the foot, called pseudosciatica, because it mimics the pain from a herniated disc. So that is why this becomes important. Coming to middle cluneal nerves, these are the cutaneous branches of the dorsal rami of L5 to S4. So we have a look at this diagram. So the sacral dorsal rami, they emerge from the sacral foramina, and they divide into the medial and the lateral branches or the lateral trunks, and then they form loops joining each other on the posterior surface of the sacrum, called the sacrococcygeal plexus or the posterior sacral nerve plexus. And they also can form secondary loops which are covered by the posterior sacroiliac ligament. Posterior sacroiliac ligament. So the nerves, they pass through the gluteus maximus muscle and aponeurosis and innervates the skin inferior to the posterior superior iliac spine. So I'll just show. So this is an image taken from Gray's Anatomy. So this forms the plexus, as I just mentioned. So this another diagram, and that which is a cadaver dissection, which shows here are the superior cluneal nerves. This is the posterior superior iliac spine, and this nerve going behind the ligament, posterior sacroiliac ligament, and so this can even continue or join the superior gluteal nerve. So a lot of permutation combinations can occur. I'll go ahead in my further slides and tell. So the branch from L5 and S1, it can run horizontally across the posterior sacroiliac ligament and passes through the gluteus maximus near its origin. So if you see here or this slide, so it passes through the gluteus maximus near its origin, and the loops form from S2, 3, and 4. They join with a similar or descending course and forms 1 to 2 cutaneous branches. And these cutaneous branches, so here will be this is the posterior superior iliac spine, and here is the medial cutaneous nerve, if you see here in this diagram as well. So from here, they can also give some branches to the sacroiliac joint or to the posterior sacroiliac ligament, and these can also be potential pain generators. They can as well communicate with either the superior cluneal nerve or the superior gluteal nerve, as I showed in this diagram as well. So Cox and Fortin, they describe the anatomic considerations for radiofrequency of these branches. There has been a wide variability in the points at which these branches they exit the dorsal sacral foramina. In almost 75% of the specimens, it's been seen that L5 contributed to the dorsal sacral plexus. Kikuta, he defined the middle cluneal nerves as starting at a point at which the branches, they form the gluteus maximus. Proximally, they are labeled the medial and the lateral trunks of the sacrococcygeal plexus. Therefore, this nomenclature, it brings the middle cluneal nerves also in line with the superior cluneal nerves, because once they also arise, they are like the way superior cluneal nerves are passing through a fascia, these are also passing and crossing through underneath the ligament. So what is the pathophysiology and the cause? So there can be any iatrogenic injury. Earlier, there were a lot of bone graft harvestings that were done from the posterior iliac crest, which would prone damage to the superior cluneal nerve. Other causes could be nerve entrapment due to any trauma, traction, friction, or repetitive compression. This would lead to edema, inflammatory cell infiltration, and scarring in the tissue surrounding the nerves. and therefore interfering with its normal sliding movement. It's also been seen that contraction of the latissimus dorsi and the gluteus maximus, they can increase tension in the fascia, and it can also again provide a second site of entrapment at the gluteal fascia. So in diseases like Parkinson's or in vertebral body fractures, it has been seen, or in cases where there is hyperactivity, so there is increased muscle tone, so which can be like a second site of entrapment of these nerves. So as far as the middle cluneal nerves, they are narrowed where they pass under or through the posterior sacroiliac ligament or through the aponeurosis of the gluteus maximus, especially at gluteus maximus because of the repeated and extensive stretching of this huge joint. So there's a lot of activity that happens like flexion, extension, and especially it has been seen that even few famous sports players who are into a lot of sports activities, they've had the risk of entrapment of the middle cutaneous nerve. Others can be like nerve root irritation, which can arise out of foraminal stenosis or a herniated disc at the level of T12, L1 or L2, can also cause this nerve entrapment. It's also been seen that the intermediate branch can get injured by a needle during a paramedian approach into the epidural space. And this can create a situation like a double crush syndrome, which is a situation in which a nerve that is compromised in one region is more vulnerable when it is injured in another area. As far as the physical examination goes, so the first point is examining at the thoracolumbar region. You look for physical findings which would suggest any anatomical basis of pain. Segmental examination could be done at the level of to provide evidence of thoracolumbar dysfunction. We would see tenderness or on gentle pressure in each horizontal direction on the spinous process, which could indicate any facet joint dysfunction, or a deep palpation of the line parallel to and 1 centimeter lateral to either side of the spinous process would also reveal any abnormal joint. We could also see that rolling of a fold of skin between fingers leads to a pain in the area of the skin which is supplied by this nerve. This is called a neurotrophic reflex. So you must always compare this to the other side or in the surrounding areas as well. At the same time, then you examine also the paraspinal and the gluteal muscles. You could see cords or muscles in spasm with or without any tender trigger points. Also palpate the gluteus medius right from its insertion on the greater trochanter to the posterior superior iliac spine and to the along the ilium just below the iliac crest for any gluteus medius weakness or any nerve entrapment in the aponeurosis. Look for the tender points on iliac crest, generally which are seen approximately 7 centimeter lateral to the midline. So there is also a variability. So it may not every time be 7 centimeter. If the patient is a bulky patient, it can be say 6 centimeter. There have been very variable reports about this also, but generally they have standardized it to around 7 centimeter approximately. Also, and eliciting the radiating pain from low back to the posterior thigh by doing hyperextension or by lateral bending towards the side opposite to the complaint or by rotation of the lumbar spine. So you can elicit the pain, radiating pain. Symptoms of entrapment of the middle cluneal nerves. So pain which is reproduced by pressure on the posterior sacroiliac ligament. And now this is approximately 3.5 centimeter caudal to the posterior superior iliac spine. And also this can cause numbness and radiating pain whenever the site is palpated. So coming to the differential diagnosis of low back and leg pain, we have to rule out all these other causes. Among the lumbar spine, we have the vertebral fractures. I think we all know that local pain is there in the affected area, which is aggravated by palpation of the fracture point, which is confirmed by MRI or bone scan. It can be lumbar disc or spinal stenosis, which can be again on physical examination and MRI, which can be concordant with the diagnosis. You can check for the sensory motor or the reflex changes in these cases. the facet joint disorders, in which the pain relief is there with diagnostic medial branch injections. Very important is the thoracolumbar junction syndrome, also called as a main syndrome, because this is at the level of generally T12 or L1. Here is what the vertebra, the directions, the face of the vertebral directions, the joints, there is a bit of alignment changes at these two levels. So this is relieved by a diagnostic injection, and this term is also used to describe entrapment of a branch of the superior cluneal nerve. We also need to rule out the SI joint disorders, in which we all know that there will be axial low back pain, and there'll be confirmatory signs on physical examination like Febers, Jensen, pelvic compression, distraction test, all those tests we need to know to rule it out. Iliolumbar syndrome, in which there will be unilateral low back pain produced by hip flexion, and Faber test will be positive, and again confirmation by local anesthetic injection into the iliolumbar ligament and relieve pain. Coming to the myofascial pain syndromes, they can be paraspinal myofasciitis. Again, there'll be trigger points in the paraspinal muscles, and these can be relieved by trigger point injections. There can be gluteus medius muscle pain or compartment syndrome. Similarly, trigger point in the gluteus medius, which can replicate the pain and relieved by trigger point injections, and or the release of eponeurosis. Piriformis syndrome, in which there will be pain with palpation of the piriformis muscle and relieved by giving the local anesthetic into the muscle. So these are among few of these, the important myofascial pain syndromes, which we need to rule out when we have pain, again, quite similar to the medial cluneal nerves or the middle cluneal nerve entrapment pains. Other nerve entrapment, which can be because of inferior cluneal nerve, which is generally also the posterior femoral cutaneous nerve entrapment, in which there is pain in ischium with sitting and relieved by the local anesthetic injections. So now this is the diagnostic criteria that the author in this article has laid down. I'll just quickly go through physical exam. I've already mentioned these points, but I'll just run through. Physical examination, in which there will be symptoms of entrapment, which may be reproduced by palpation of the tender points, hyperextension or lateral bending to the side opposite to the affected site. The diagnostic injection may be done with 1 cc of local anesthetic using either the landmark technique or ultrasound or fluoroscopic guidance. In ultrasound, the nerves may appear as small hypoechoic structures just inferior to the border of the eyelid crest. X-ray findings may be a little non-specific, but they can help us rule out any vertebral compression fractures, which can increase the level of suspicion for any superior cluneal nerve entrapment. MRI, again, just to rule out other causes of low back leg pain. CT scan, they may show a bony groove at the osteofibrous tunnel. So that can be important for us. Electrodiagnostic studies are not useful for this. As the treatment goes, the non-invasive therapies involve the conservative approaches using medications, the physical and the chiropractic therapy or acupuncture. Injections can be given using landmark, fluoroscopy, or ultrasound guidance. Coming to the landmark technique, the position is standing flexed at the hips or in a prone position. You palpate and mark the posterior eyelid crest, as I told earlier, around 6 to 7 centimeter lateral to the midline and at the point of maximum tenderness. Using aseptic technique, you advance a needle of 1.5 to 2 inches, around 25 to 22 gauge needle, perpendicular to the skin till you contact the bone. For diagnostic purposes, you do a negative aspiration and inject around 1 ml of the local anesthetic or steroid. Or even a peripheral nerve stimulator can be used to identify the proper site of injection. As far as the middle cluneal nerves go, there is no landmark guided approach described in literature for them. However, consistent with the physical examination, locating the middle cluneal nerves by finding the site of maximal tenderness with palpation medial and just inferior to the posterior superior iliac spine, it is likely to be like a blind SI joint injection. So these are generally also, you may call them as blind SI joint injections or middle cluneal nerve injections. I don't know how far it is correct, but I think others who are more experienced into this may be able to highlight. So fluoroscopic guided technique. In this, the point of maximal tenderness for the superior cluneal neuropathy is usually at the medial iliac crest. So if you look at this diagram, so this is the medial iliac crest, and you look for the point of the maximum tenderness, and there's this traction spur of the attachment of the ilio-lumbar ligament, which can be seen here, nicely visible. Palpate the area to confirm the target and inject 1 ml of local anesthetic or steroid solution to the top of the iliac crest. Now, middle cluneal nerve. So in this, as we see that again, the point of maximum tenderness, which is just below the posterior superior iliac spine, generally it corresponds to the S2 level. S2 level, so this is the S2 level, the lateral border of the S2 level, and 1 ml of the local anesthetic steroid can be given here at the S2 foramina, lateral border of the S2 foramina. You can also see in this, the needle with the stimulator is here. In ultrasound guided technique, the position is prone. You palpate the posterior wing of the iliac crest, approximately 6 to 7 centimeters lateral to the midline, and mark the area. A high linear frequency linear probe is used in a transverse view. The iliac crest is visible as a bony shadow. Move the ultrasound probe little superior and posterior from this point, and this will reveal the superior cluneal nerve as a small hypoechoic structure inferior to the border of the iliac crest. And then you can use an in-plane or out-of-plane approach to local anesthetic and steroid injection. Identification of the middle cluneal nerve can locate the most posterior and inferior point of the superior iliac spine, posterior superior iliac spine, and using this as a reference point to find the second sacral foramina. So approximately 2 to 3, so you can see, centimeter below the posterior superior iliac spine and 45 degrees below the horizontal line. I think I have never used this, so I'll not be able to throw too much light on this aspect. But I guess Dr. Aanchal or people doing the ultrasound maybe shall be able to tell more detailed about how do you go about it. The first sacral foramina is then counted as generally 1 to 1.5 centimeter above, and then the third is counted as 1 to 1.5 centimeter below the, taking this as a reference, the second foramina as a reference. Neurolysis, if pain relief from diagnostic injection is complete but only temporary, then longer lasting modalities could be used like cryoneuroablation, radiofrequency lesioning, or chemical neurolysis. Other options include peripheral nerve stimulation or surgery. So here we will mention a bit about cryoablation. In this position is prone with a aseptic technique, infiltrate a small amount of local anesthetic subcutaneously using a small gauge needle, and then you pass an introducer catheter, 12 to 14 gauge with a sharp stellate to the target area. I'll just quickly run through. I think we're running short on time. So here, advance the cryoprobe, and then you check for the proper probe placement, and a series of 2 2-minute freezes with 30 seconds of defrosting in between the cycles is to be given. I'll show this diagram. It is important. This is the cryoprobe, and this will be what it will look like for a superior cluneal nerve, the image, and this is for the middle cluneal nerve. So here, where the S2 foramen. So radiofrequency lesioning, this is a technique again very similar to how we are doing the cryo lesioning. And the target identified, local anesthetic is given, radiofrequency probe is advanced, and you check for up to the target site, which could mean either the iliac crest or the lateral S2 foramina, depending whether we are doing a superior cluneal nerve ablation or middle cluneal nerve ablation. The sensory stimulation and absence of motor stimulation has to be done, and lesion is made using the same parameter that the practitioner would use for the medial branch ablation procedures. And relief of symptoms from middle cluneal neuralgia also has been reported with the use of radiofrequency. Internally cooled probes to create larger lesions can also be used at the sacral sites. Neurolysis can also be done using alcohol or phenol. I don't know if people are still doing, I don't know. Indication, treatment of persistent pain caused by entrapment of the medial branch of the cluneal nerves, cluneal nerve, using 1 ml of 0.5% lidocaine followed by 1 ml of absolute alcohol, which is 100%, can be used. And after 1 week, the pain, if not was not resolved, then the procedure was repeated. It was studied that 4 described patients were observed up to 4 years and none reported complications after this. So apparently, I think it proved good. The other techniques are peripheral nerve stimulation. In this, there's an image for the medial branch of the superior cluneal nerve. A stimulator has been placed across the top of the iliac crest. I'm not going in much details in this because the next speaker will be mentioning, I think, in greater depth. So there's a wireless peripheral stimulator system. These are the newer technologies, so little literature is currently available about this. This is for the middle cluneal nerves. You see the stimulator, which is lateral to the sacral foramina, lateral to the foramen and medial to the SI joint. And the stimulator is then tunneled to the small subcutaneous pocket and coiled in the fascia. And these are connected wirelessly to the external power pack and a wearable antenna assembly. So complications are like, I think I can omit these because they are the general standard complications which would happen or which we need to take precautions with all the interventional techniques. So I'll not take too much time with this. So finally, a discussion, the entrapment or injury of the lateral branches of the dorsal rami of T11 to S4. They can be a cause of severe debilitating low back and or leg pain. So understanding the long and complex path of these nerves is a key to evaluating this. The clinical triad, which defines the cluneal nerve neuropathy, it includes a deeply aching and poorly localized low back pain with a variable pattern of referred pain to the buttocks and or the legs. The presence of a tender point at the iliac crest or caudal to the posterior superior iliac spine can be felt. There is relief of symptoms by a low dose of local anesthetic injection at the tender point. The notably absence of dermatomal sensory changes and muscle weakness has been seen, which would generally be seen in disc abnormalities or spinal, in cases of spinal canal stenosis. So having the patient point to the site of pain can really help us to treat and diagnose this low back pain. So finally, the concluding it, over more than a century, the long and the complex course of the relatively small lateral branches of the lower thoracic, lumbar, and sacral dorsal rami has led to often very confusing representations of their anatomy. So this modified scoping review has clarified these discrepancies and serves as a basis for the appreciation of the role of cutaneous terminal branches and the superior, middle, and the middle cluneal nerves as a possible cause of patients' low back, buttock, and or the leg pain. Although it is a relatively rare cause of low back pain, but superior and the middle cluneal entrapment is under-recognized and therefore under-treated. So this lesion should be included as a part of the differential diagnosis of the low back pain in the presence of buttock or leg pain. Thank you. Very complicated topic.
Yeah, no, you presented it well. I mean, it's a great detail of anatomy, and whatever you presented, the next presentation, all the understanding lies in anatomy only. So as I said, our next presenter had to go to his hometown because of family emergency, but I will present his presentation.
Can stop sharing my screen.
Yeah, you can stop sharing your screen. So I'll quickly present and then we'll discuss at the end. So everyone can see my screen?
Yes.
Yes, okay. So, I haven't changed his name since he's the one who presented, who made this presentation and with such an effort. So the other topic we chose was peripheral superior cluneal nerve stimulation, combined fluoroscopy and ultrasound technique. And it's a case series of 6 patients, which we'll discuss. So as you all know, chronic low back pain, cluneal neuralgia is one of the causes in which low back pain can happen. And the superior cluneal nerve, peripheral nerve stimulator may help manage pain with minimal invasiveness. Since low back pain is, leading cause of this disability in so many adults, the traditional intervention sometimes helpful, sometimes not. And the emerging evidence suggests that in certain patients, especially if the pain is neuropathic in origin, this peripheral nerve entrapment syndromes can happen. And one such culprit is superior cluneal nerve. So anatomical overview, I mean, Dr. Chandramukhi has, talked in detail, but just this paper does not talk about middle cluneal nerve. It just talks about superior cluneal nerve. So it arises from dorsal rami of T11 to L5, we just saw, and there could be various permutation and combinations. The key anatomical feature is its course. When it originates, it courses over posterior iliac crest, approximately 7 to 8 centimeters lateral to the midline. There could be an entrapment site like osteofibrous tunnel through thoracolumbar fascia. And clinical significance is entrapment or irritation can cause localized or radiating pain in lower back, mimicking the lumbar radiculopathy. So superior cluneal nerve entrapment neuropathy is underdiagnosed because of its symptom overlap with other pathologies like lumbar PIVD, SI joint, etc. And different causes we saw, entrapment, and the symptoms are sharp burning or aching pain in the posterior iliac crest, pain radiating to the upper buttock, which is worsened by standing, walking, and lumbar extension. And tenderness on palpation is 7 to 8 centimeter lateral to the midline, which can help us differentiate from lumbar facet, which we see really close to the spinous process or over the facet joint. This tenderness is really lateral, actually. So this is the anatomy. This pictures are not from this paper, but just to help understand more about the anatomy. The lateral nerves are shown. Not that the L1, L2 gives only lateral branches. It's just the representative. If it were to give lateral branches, this is how it will go. If it were to go superior cluneal nerve, this is how L3, L4 it will come and over the iliac crest. And if they were to give medial branches, L5S1 is just representing it. And if you see superior cluneal nerve, right now it's coming from L1, L2, L3, and this is how they will cross from medial to lateral over the iliac crest. So the objective of this paper was to evaluate the effectiveness of microlead sprint peripheral nerve stimulation using combined fluoroscopy and ultrasound guidance. It is a retrospective review which was conducted on 6 non-consecutive patients who underwent this system implantation. And the duration of study was from 2021 to 2024, since they followed the patient up to 2 years. So it is a targeted neuromodulation technique involving electrical stimulation of specific peripheral nerve to modulate pain signals. For superior cluneal nerve related pain, it offers several advantages, like it is a targeted approach with minimal systemic effects. It is minimally invasive. It can restore normal function, reduce central sensitization, and high specificity for neuropathic components of back pain. Criteria which they used for selecting the patients were chronic pain unresponsive to conservative treatments, tenderness at PSIS, and positive diagnostic blocks and normal MRI findings. So implantation used both combined fluoroscopic and ultrasound guidance, we'll just see in a second, and accurate localization above the iliac crest and adjacent to specific muscle planes. So technique, I'll discuss what they have shared with us. They said that first you take AP X-ray view where you identify the iliac crest. And the tip of the lead, you'll imagine at this point that it will be positioned 7 centimeter lateral to the midline. I've taken this picture and you can see this, the lead is 7 centimeter lateral and it is half and to 1 centimeter above the middle third of the iliac crest. So just, we'll have to localize that this will be our final position for the lead placement. So you take the AP view first and identify the iliac crest. And in this image, I also want you to see that, this transverse process is close to the iliac crest. So it will help us understanding the ultrasound. So once they have taken the AP view with the help of X-ray, they use the ultrasound and, medially, where they put the ultrasound, I'll show you in a second, like this is how, this picture is again not from this paper, but I just wanted everyone to understand more, how it will look like. If you put a probe, like, we do QL blocks, for example. So the iliocostalis part of the ESP muscle, erectrospinae muscle, and posterolateral part of the quadratus lumboris muscle will be medially. So if you pay attention to this picture, so QL and erectrospinae are medial. And then the laterally will be the medial aspect of latissimus dorsi muscle and iliac crest lateral to the transverse process, L4 transverse process. So this is the picture from this paper. It shows ultrasound orientation in an oblique view. So this is an oblique view where the probe is positioned medially and cranially. So the medial portion will be cranial and the lateral portion will be caudal. So, and they are introducing the introducer in this position. So this is how, and then they, took the X-ray picture when they, after introducing 20 gauge blunt introducer, which was advanced using both ultrasound and fluoroscopy. And this is how it looks like in AP view. And you can see it is medial to lateral. And this is how the contralateral X-ray looks like. It's the same thing from front and then the contralateral view. And then, the introducer cannula, through the introducer cannula, they deployed the lead. They haven't showed the, the full lead, but the lead comes like this by applying gentle pressure over the needle tip and lead location. And then proper placement was confirmed by patient's feedback who reported a comfortable vibration sensation in targeted nerve distribution area. And then finally, they verified AP and lateral views, X-ray views above the middle third of the iliac crest. And ultrasound also confirmed that the lead tip is in the lateral third of erectrospinae muscle, just cranial to the iliac crest. So after placing this, what they measured as outcome criteria was pain reduction, improvement in daily living, opioid usage, and complications. So the mean baseline pain score of all the 6 patients were 7. 5 out of 6 patients showed more than 50% of the improvement, and there was variable opioid reduction outcomes. So this is the picture you can see. Pain score before the intervention, average is 7. It was like from 10 to 5. And then after 30 days, it reduced to 3, which stayed same at 60 days. And the 90 days also, it kind of stayed same. And average score was just 4.5 at the 2-year intervention. And then you can see the, percentage of patients who still had relief at 2 years was 50%. But then it is a case series of only 6 patients. We have to remember that. So, pain score before the intervention, and you can see at the end of 60 days and at the end of 2 years, 2 were lost to follow-up, but then mostly they have from 2 to 4. 1 patient pain came back to 7. And this is also opioid usage, pre-procedure. 3 out of 6 patients had opioid usage, and 1 stopped it. And this is like pre and post procedure score. You can significantly see from 10, 8, 7, 9, it went to 4 to 1, and 1 patient stayed at 8, and we'll discuss in a little bit. So this is the same thing, 30 days, 60 days, 90 days, and 2 years pain scores. So they have discussed, individual patient. In patient 1, they did a diagnostic block, which gave 80% of the pain relief. At 2-month follow-up, The patient did have improvement in back pain, but the local infection was there, which was treated with antibiotics. And at the end of 2 years, there was no improvement, despite the individual block had fantastic improvement. Patient 2, 50% improvement, which persisted at 2 years. Patient 3, 90% pain relief, also improved sleep and walking. But at the end of 2 years, it was reduced to, it was still at 50%. Patient 4, pain relief along with improvement in activity persisted at 3 months, but patient was lost to follow-up at 2 years. Patient 5, that patient did have a pain relief, but she could not tolerate the discomfort from the external pulse generator, so she requested early removal. And patient 6, pain relief persisted months, even after 5 months, bleeds dislodged, but somehow the pain relief persisted. So, in the discussion, they have shared other studies, which was done in 2013, 8, 20s, which showed similar kind of pain relief after the superior cluneal nerve stimulation. One was a pilot study, and another they did a RF lesioning and neuromodulation, which also demonstrated sustained pain relief. And there was a recent RCTs which indicated that patient with positive superior cluneal nerve block and targeted stimulation did show improvement in VAS and their ODI scores. So benefit out of this you get is reduced pain score, improved functional outcomes, reduced need of opioids and analgesics, and higher patient satisfaction. So it's a similar thing. Ultrasound helps minimize X-ray exposure and increases precision. The risk and complications, it's generally safe, but of course it has risk of lead migration and dislodgement, like they did have in one patient. Local tissue irritation, you could have device malfunction, or paresthesia or discomfort with stimulation. So future directions to the study will be, you can have miniatured wireless peripheral nervous system, which are coming up, combined imaging and EMG mapping for precise targeting, as we know that the nerves are so small and hard to localize. And there are ongoing clinical trials to standardize protocols and long-term efficacy. And we also can have AI-driven closed-loop neuromodulation now. So they concluded that the combined ultrasound and X-ray guided superior cluneal nerve, peripheral nerve stimulation is a promising method to reduce pain and improve quality of life in cluneal neuralgia. So these are the references given in this. Thank you. So this is open to discussion. Amod sir, can we have few comments from you, and you can share your personal experience as well. To unmute yourself. Yes.
Yeah, I was just looking for the button to unmute myself. Yeah. No, so it's, I think the first article is quite good, and there is lots and lots of publication. I think the main agenda of this should be to make people aware of that there is something like cluneal nerves which are there. I have diagnosed it previously, had positive results. But the key is to keep it in mind when you see a patient and there are so many differentials which you try and exclude first. A lot of people lose faith. And it becomes very difficult for them to, especially in the private sector, to continue funding their treatment and to believe that there could be something else. And the concept of, especially in India, telling someone that it's a diagnostic injection when 2 other injections haven't worked before becomes a real challenge. But if you keep a very focused view that, okay, nothing else is fitting and I've ruled out everything, there are, and some of them, when you see them, if you remember the exact symptoms, this is the first thing which will click you that this could be that. And I mean, like if you have access to ultrasound, then it's an OPD procedure as well, just putting in 1 ml of local anesthetic. But the resistance comes from the other side, not from our side as a diagnostic tool. But the biggest challenge is keeping it in mind and keeping it in the list of differentials. Even after attending the seminar, I can tell you that I have been presenting on this topic since 2015 or 17 or something like that. And even after that, sometimes it strikes me after the patient has left that maybe when I'm thinking really hard, this is one thing which I forgot, having diagnosed and doing other things as well. So just keep it in mind and use whichever modality is best in your hands. I personally think ultrasound has got a superior edge compared to fluoroscopy in this. because very often you would not see the tractions per which is typically shown in the X-rays. Very few patients will have that. So ultrasound, and especially even if you see that, getting the depth right is the key, which X-ray doesn't give you that idea. So the ultrasound is, I feel, got an edge. It's an essential part. And don't flood the area with local anesthetic, because that's not productive. Do a bit of hydrodissection, yes, local steroid, your choice. But if you do get positive result, I try and repeat it again to make sure it's not the placebo and to optimize as much as possible. And sometimes with the second diagnostic, they get better also. And I don't need to repeat it, or it doesn't come back soon. And the superior medial one is the most common one. That's the one I've diagnosed most often. Inferior, never. Not because it's not been on my mind, because the diagnostic criteria and the symptoms can be really challenging, and the depth in that area becomes too much to precisely target them, especially when you cannot see them. Using a nerve stimulator is an advantage. I try and use that often. Not often, always, if I can, because that if I can replicate the symptoms, then that's really great. With regards to the spinal stimulator for this indication, no, I've not seen it being done. And I think reading too much into single center, 6 case, thing with no blinding is probably, you can take your own call in it. But yes, I have seen that this is becoming more and more popular with the especially with the non-bulky, easy to put leads. Unfortunately, I've tried to contact a few of them, but none of them are available in India as far as I know. The big ones are, but the small ones, they all have their advantages and disadvantages. Some can be left in for some time, some can be left in longer, some have battery issues, but there are plenty of companies, but none of them are available in India or willing to come as of now. I keep checking every now and then. So that's all I have to say about it. Yeah.
I think we have a few questions. We can take Ashu sir's comments.
Yeah. So till date, I have experience of 2 patients, one with in Rajat's time and one after that. Only 2 patients which presented to as piriformis syndrome like, and we did ultrasound guided piriformis injection, no results and confusing. And in both the patient, we gave this S2 S3 sacral plexus block under fluoroscopy. And like we do cooled RFA or SI RFA, joint RFA. So because we read this importance of middle cluneal nerve and this sacral plexus there, S2, S3 foramen. So followed diagnostic block in both the patient. We did this conventional radiofrequency ablation in one case and cooled RFA in another patient at S2, S3 lateral to that foramen, the ridge between the S2, S3. And both the patient worked very nicely. So I have total experience of 2 patients in my career with this kind of piriformis kind of syndrome coming to buttock and going down to back of the thigh. This is all we have, and again this is a diagnosis of exclusion, and you don't know, most of the time you are lost and making differential diagnosis. And this is what I have in my experience. But in both the cases, we did S2, S3 branch dorsal rami fluoroscopy block and followed by RFA. One in Rajat's time when cooled was not available, so we did the conventional one that we used to do. And year back we did this cooled radiofrequency.
And then this middle cluneal nerve is close to S2.
Yes, so what we did the conventionally as we do S2, S3 reach, sacral plexus for the sacroiliac joint, the same technique. And it works very well because I think that dorsal rami is only coming laterally and forming this middle cluneal now.
Yes.
So I think
Okay.
very good evening, ma'am.
Good evening.
Good evening, ma'am. Ma'am has been very kind enough to answer our questions as well.
So we will utilize her experience. No? When she has
So I'll just
Yeah.
quickly, take 1 or 2 minutes to
No,
what
no,
I
ma'am,
have penned down.
Yes.
Because we'll take up more questions. So as told, it is a diagnosis of exclusion. But we need to be aware of this entity as this is one of the important DD. Okay, if we are not aware of it, if mind doesn't know, eyes will not see it. Okay, so then we will not keep it in the differential diagnosis. And I'm sure Dr. Ashu and myself would have missed it. What he says, he has only 2 patient experience. It is not just that because there would be only 2 patients.
Yes.
We might have missed it
So
because
many.
we did not know about it. Another is history is very important, and for superior medial branch, superior cluneal nerve medial branch, it is the tenderness at the iliac crest with buttock tenderness is most important. Okay, so the diagnosis is done most of the time by history and examination. About CRF to be avoided because it is a very superficial nerve. So if we are going to do conventional RF and using 60 to 80 degree temperature, there are very high chances of skin burning. So
Yes.
So cryo and cooled should be done. If you do not have cryo or cooled, PRF may be a modality of choice. Also about I'll just share my experience of this Wednesday. We had a patient and we examined. We see 50 to 70 patients in one day. Patient jab aaya first time mein, we thought that this is an SIJ pain. We gave SIJ injection. My fellow is here. My first fellow is here, Gauri. We gave SIJ. He came back to the Wednesday, this clinic. There is no relief after SIJ diagnostic, correctly placed SIJ injection. And now this patient says, I have a pain at the iliac crest. There is a tenderness, which is actually 6 to 7 centimeter lateral to the spine. And now we have made the diagnosis of superior cluneal neuralgia, and we have put this patient for the diagnostic block. So this is what I say, and I've seen around 8 to 10 patients or maybe more, but these were only recent advancements of last 5 years or 4 years since we learned that this can be one entity. Also, now we have a free availability of ultrasound. So we do all the procedures ultrasound guided, and that where you can really see hyperechoic structures, and it is very nicely seen. I think we can later share any video where you move from the iliac crest lateral to medial, or the way Aanchal said, you can identify the transverse process of L5 and then move lateral, and it is beautifully seen 2 or 3 hyperechoic structures, round structures, and if you make them medial edge cephalid, then you can also see the long axis of these nerves. Okay. Also, one point to say that these lead placements are retrograde, not like antegrade in the spinal cord stimulator. So lead placements are always retrograde, and we place the battery above that. And about us, we do not have the PNS available to us. None of the company is come to India.
Yeah, it's not
in India. Yeah. So what can we do? What can we do if we do not have PNS? We have cryo cooled. And what can we do as a peripheral nerve stimulator? So which is a very jugaad, what we can do? We take a nerve stimulator, maybe stimulate it for not just 1 or 2 times, stimulate it for 2 to 3 minutes in some bursts. So this is where we discussed with Dr. Joyshri that this can be done in India if we do not have PNS. And PNS is very expensive. It is 6 to 7 lakhs per lead. So these are my comments. And I wanted only 2 minutes, so I rushed. Now we can take up other questions from the delegates.
You have answered most of it. Like, I'll just read it for everyone's benefit. They've asked, will bone marrow biopsies at iliac crest land up in superior cluneal nerve? And we know that it has been discussed. It's a very common cause. Nobody will tell, actually, this is just my experience, patient will not tell that, I've had bone marrow biopsy, because it is just a test done on the OPD basis. So if the patient has a history of lymphoma, leukemia, or thrombocytopenia, and then you can just ask, and patient presents with a similar pain, whether, any test was done from, this bone. So this is like the retrospect history you can take. And the other question also, any specific demographic risk factors, I don't think so. Any demographic I can have. Dr. Amod sir can answer. Do you see like any post demographic?
Sports people, especially fast bowlers, tennis players, when the hip goes from
Okay.
full range from flexion to extension and the trunk is flexed, that's
Okay.
one of the common things because that stretches the quadratus lumborum fascia and that stretches the gluteal muscles and makes the nerves very taut. So fast bowlers and similar profile people, tennis
Okay.
players, when
So
they do
we
a
can
serve, yeah.
just have that in mind that when they come. And then any specific exercises to prescribe for superior cluneal nerve neuralgia? Any of our experts can answer that. Any maybe core strengthening or I don't know.
So anything which relaxes the muscles above the iliac crest is good. Anything which tenses the glutes is bad because that squeezes the nerves more through the fibrous opening. So that
Like
is
even
what you have to
stretching would be
tell-
more helpful. Like
that is what you have to tell your physios and then let them work on it. That's what I say to them when I suspect that.
okay.
But what you should avoid is anything which increases the pain. So entrapment should be avoided.
So contraction of the glutes, like those kind of
Yes.
exercises. Okay.
There's also in one of my slides I mentioned, like in cases of Parkinson's disease, when there can be tense muscles, hyperactive muscles, like as Dr.
Pain
Amod
can
also
be
mentioned
worsened
about
in
sports
that.
people.
Yes.
Yeah, so similarly in Parkinson's or vertebral fractures, also there is more tension in the muscles. So in those cases also there can be high chances. That's one of my slides I mentioned.
Yes. Okay. So I think PNS, it's not available in India. Ma'am already answered that. So I have two announcements to make. We have incoming, in-person meet on 6th of September, which I will be sharing soon. So everyone is invited. It's just an informal meet followed by dinner. We'll have two interesting, presentations in that. And if there are any students here who wants to participate in this journal club presentation, they're more than welcome. They can, message me or email us or just leave your comment we'll be posting this video in YouTube. And